Hello everyone, welcome to the renal lecture. We're going to talk about two major concepts of renal disease and management. The first is going to be chronic kidney disease, the second is going to be acute kidney injury, and we'll talk about some ongoing maintenance things that aren't necessarily directly related to the kidneys, but would be something somebody with CKD would take regularly. So we've talked about the kidneys already. We've talked about creatinine clearance and how important it is for drug calculations, but the kidneys also are responsible for eliminating the majority of waste products that come through that our body processes. So anything the liver is converting into a more polar molecule to get rid of will go through the kidneys. Kidneys are also responsible for acid-base homeostasis and managing electrolyte balances, so getting rid of extra sodium, potassium, or retaining that if it's low in the serum. It's a biosynthetic organ, so it makes a couple things that are very important. So erythropoietin, which stimulates red blood cell production, vitamin 3 specifically, and renin. And then it works as a buffer system as well with producing ammonia. So that helps with the certain different homeostasis, kind of back up to the acid-base concept here. It also has some metabolism. It metabolizes some different peptides, which you can see there. So the kidney has a lot of functions. More so, I think we generally just think of it as making urine, getting rid of stuff, but it also does quite a bit more than that. So when people do have kidney failure, you'll see sort of all of this stuff fail in different states. So when we talk about replacing or managing kidney disease, we're going to be talking about replacing all of this, all the functions that we see here. CKD staging has been basically the same for quite a while, and it's mostly based on GFR. So if you go back to my first lecture, if you remember back to that, we talked about two different ways of calculating GFR, the MDRD equation and the Cockcroft-Gault equation. So this is going to be the MDRD equation, which you should know, which you can know because of the 1.73 meters squared designation on the units. But basically, it's calculating how much volume per minute your kidneys are producing in urine. And if it's above 90, that's a normal person. Once it gets a little bit below that, you get a little concerned and think, well, there might be some mild kidney damage, and then you go down from there. You can be a stage 4 or 5 CKD and not be on dialysis, but generally speaking, once you get under 15 or even under 30, even in some patients of creatinine clearance or GFR, I should say, you're going to be looking at having that patient be a dialysis candidate. Just because their body's not going to be able to process any waste. You're going to accumulate a lot of electrolytes, which can cause significant issues, which we'll talk about in the next major lecture. But ultimately, you're going to need some way to get rid of those excess products, and that's where dialysis comes into play. So I won't be talking a ton about dialysis. We'll touch base on it towards the end of this section, but we will talk about kidney disease and how you manage sort of those in-between steps and how we can help the kidneys out a little bit, how we can protect the kidneys, and what we might need to replace once the kidneys start to fail. This slide is an exact copy from that first lecture about pharmacokinetics in the beginning of the semester. But just to review what the differences are in the equations. And remember, the Cockcroft-Gault equation is for drug dosing primarily. That's where if you read a drug monograph and it says to renally adjust based on this creatinine clearance, that's where the Cockcroft-Gault equation is used. And the MDRD equation is going to be used for our CKD staging. Once again, all right, here's my funny joke. All right. The nice thing about what we're going to start talking where we're going to start our discussion today is diuretics. And we've already talked about diuretics. In fact, we spent a lot of time talking about diuretics during the antihypertensive lecture. And you use pretty much all the same diuretics for CKD. So the concept here, just generally speaking, is diuretics help push fluid through the kidneys. So if your kidneys start to fail and they aren't moving as much stuff through, diuretics can help augment that process. Now, there's a little bit of a double-edged sword there because the more diuretic dependence you get, generally speaking, the more significant CKD you get as well. And ultimately, diuretics can have significant impact and cause kidney damage, especially if somebody gets hypovolemic. So if they get fluid under at some point because they're maybe being over-diuresed, you can end up with increased kidney damage and what we call an acute on chronic situation, where somebody has chronic kidney disease underlying, but they also have acute kidney disease on top of that. So getting a little bit ahead of myself here, but the point is we've talked about where these drugs work for the most part. We've touched on loop diuretics and how they're used in heart failure. We've talked about thiazide diuretics and blood pressure and potassium-sparing diuretics. So a lot of this stuff that we're going to cover, we're talking about some of the same things we've already had, but we're going to talk about these in a little more detail as far as how we use them in this particular disease. So the site of diuretic action, just to review, and what was shown on that diagram I just had up, are listed here in text form in case you want to look at how things are broken down in a more textual context. Osmotic diuretics, you can basically ignore this for now. We don't use osmotic diuretics directly to diurese somebody, and we certainly don't use them in CKD. Sometimes they might if somebody has like an acute kidney disease, acute kidney injury due to some odd circumstances where they have significant muscle breakdown. But for most patients, mannitol and other osmotic diuretics aren't going to be useful. So again, you might see this in certain contexts, but it's going to be quite rare, and probably only in trauma is where I would maybe see it most, where you have maybe some sort of a large muscle getting crushed and inducing lots of proteins and things being sent into the bloodstream, and then that can cause kidney damage directly. In acute kidney injury, mannitol might be useful in those types of situations. But we mostly use mannitol for intracranial hemorrhage for bleeding because it changes the concentration gradient. And all mannitol is it's basically like a big solute that just changes the concentration gradient between the lumen and intracellular space throughout the body. So again, we like to use this if somebody has a head bleed going on. The idea is you can give mannitol and then hopefully keep some more fluid within the intravascular space versus having it bleed out into the peripheral cells and things like that. So that's where mannitol's role is. Again, don't worry about mannitol for CKD. It's not a huge thing. I just wanted to cover it because it is technically an osmotic diuretic and it does have maybe some niche uses, but nothing we're going to be concerned about for this class in this particular module. I'll come back and talk about this a little bit during a critical care neuro section next summer, but otherwise mannitol doesn't have a huge use. Carbonic anhydrase inhibitors also aren't used very often. However, they do have some functionality that can be beneficial, and they're sort of unique medications. There's really only one out there. There are others, but acetazolamide is the one that I've ever seen, only one I've ever seen used. It comes PO and IV. It doesn't really have great diuresis effect, but it does have some changes in the way that fluids can be. Again, it's not quite like mannitol where it's changing the concentration gradient directly, but working with altering how sodium is resorbed, it can change the way fluid shifts within intracellular and extracellular spaces. So that can help in certain contexts too. The reason I'm putting it in here because I don't really talk about it anywhere else, and there's not really a point in doing a lecture on things like carbonic acid accumulation, like if you go up into high altitude areas. So one thing that acetazolamide is used sometimes for is people who are going mountain climbing. They might take it because it actually forces the kidneys directly to excrete bicarb or CO2, and you're going to acidify the blood that way, which acts as a respiratory stimulant and compensates for hyperventilation in high altitudes. Now you can see how this might help if your kidneys are failing. They might be able to use a drug like acetazolamide to also push out more bicarb if you're getting an excessive acid-base imbalance. Because bicarb is your form of base within the blood, right? So when you're doing looking at like a regular lab report, you see the CO2 or the bicarb or the base or however they report it, that's what they're looking at. So you can use this drug potentially in patients with kidney disease to help with that particular dysfunction. But other than that, you're probably only going to, if you ever prescribe this drug, it's probably going to be people traveling and going on high altitude hikes, which sounds great, but that's a whole nother topic. So loop diuretics are our mainstay drug for forcing diuresis within the kidneys. Remember, they're our most powerful diuretic. One of their negative effects, or maybe disadvantages would be a better word, is that they have to get secreted into the tubular lumen in order to be effective. So if they can't get to the site of action, they can't really do anything. So for people with really advanced CKD, you can only force diuresis so much until they just aren't going to work anymore. So like that's why we need dialysis, because once the kidneys are damaged to a certain point and just aren't working at all, or working very slowly, or producing very small amounts of urine, even if you give somebody really high doses of loop diuretic, you can't get them to the site of action because nothing's happening there, and that organ's basically failed at that point. So we can use loop diuretics to augment the kidney's natural processes for patients who are in those middle stages of CKD, and that works pretty well. But once they get further down, they just aren't going to be effective anymore. So they act on the lumen side of the nephron, and then they also, and then just to remind you their mechanism of action, they inhibit the potassium-sodium chloride cotransport system. So what you have is potassium and sodium remaining within the lumen and getting excreted. They have weak venous dilation effects. They don't change blood pressure too much, but they will have some transient effects on lowering BP just a little bit. And remember, we have three choices here, and they're all interchangeable. Torsemide and bumetanide are generally the two more potent ones out of the three, but they're all basically useful for the same things, and there's no studies that say one is better than the other. This slide might come in handy for you later in your career. I get this question a lot from providers because I don't think there is a really great source out there. Like if you Google this, sometimes it's hard to find something exactly like this. And I'm not saying this is perfect, but comparisons between the three loop diuretics. A lot of times you might get a patient who comes in and they're on furosemide and they're on a certain dose. You might be like, okay, well, I want to give them a little bit more. Like I want to double their dose. How do I do that? And this chart like this might help you figure out like the dose equivalent. It's probably the most important thing from a practical aspect. Now, I'm not going to test you on this, but this should give you a little bit of a comparison for how these drugs work, bioavailability, it's like that. So for example, one of the big differences between furosemide and the other two is that the PO dose is double the IV dose. So a nice, easy way to remember, and this is a little pearl of wisdom, is if you have somebody who comes in on furosemide and you want to increase their diuretic, give them the exact same dose they take at home, IV, because then you're doubling it. So if they take 40 milligrams a day at home, and you give them 40 IV, you're giving them a total of 80 of their home dose, because the bioavailability is low on furosemide. And when you give it IV, of course, it's 100% bioavailable. So you're giving a significant amount more just because you're giving it IV versus PO. Torsemide and bumetanide are essentially close enough to 100% bioavailability where they're 1-to-1 equivalent. It's not exactly, of course, but you know, for our purposes and for the purposes of clinical relevancy, that's the case. And then you'll see the conversions here. Now, the torsemide conversion is a little bit debatable. I've read different sources where 20 milligrams corresponds to 1 of bumetanide, and other sources say 10 correspond to 1. I think anywhere in there is fine. Just know it's not an exact science going from one to the other, but generally the trend is that furosemide is the least potent, torsemide is kind of the middle road, and bumetanide is the most potent of the three. So if you have somebody who's not doing well or responding to furosemide, you can get maybe some added benefit by switching them onto a different one. This slide talks about different indications and doses. So again, I'm not going to test you on this specifically, but just to show you kind of where people are at for a daily dose of furosemide or loop diuretic in general, what you might see commonly. A lot of times people split up their loop diuretic, and remember that these drugs work relatively quickly, so your half-life depends a lot on how well your kidneys are functioning, especially with furosemide. Like if you're advanced CKD, your furosemide is going to stick around the body quite a bit longer because it's just not getting to the site of action. Whereas torsemide and bumetanide are hepatically processed, so they'll be metabolized regardless of kidney function. Now, where that comes into play is with different indications and dosing. You might see people take their dose all in the morning. Sometimes you see people do a split dose, though, which is really common. So they might take a dose in the morning and then one, usually in the afternoon, as their second dose, and that sort of bridges it. If you think about, let's look at the average of this. Let's say they work for about 4 hours as far as diuresis goes. They work for about 4 hours or so. Let's just say that's, you know, kind of the the midpoint here. Even if the half-life's shorter, even if you give a dose of Bumex, it's going to stick around for a while. It's not going to stick around for a while, but the kidneys are still going to work off of that diuretic effect, and you're going to get continued diuresis post the half-life of the drug. So it's a little misleading. But the point is that you can sort of bridge people. So they take some in the morning, and then maybe 8, 10, 12 hours later, they take another dose, and that gives them continued diuresis into the evening. One pretty much absolute truth with diuretics, especially loop diuretics, is you do not give them in the late evening hours or at night. I do talk to some patients who take them in the evening, their second dose, they'll take it with dinner, and maybe they know well enough where they know that the diuretic effect wears off by the time they need to go to bed. The last thing you need is somebody trying to sleep and having to urinate constantly the whole night, because that is what will happen. And then people will just need to get used to these drugs too, and how they affect their urination, and make sure that they have access to a bathroom readily until they can know more about how the drug's going to work in them. So they might know that, well, after I take my Lasix in the morning, right at about 2 hours, I really have to pee, and then it kind of keeps going for the next couple of hours. So they might be able to plan errands around that kind of stuff. But just to educate your patients on those types of things, it's really important when you're using diuretics, especially loops, because they're so potent. This chart I pulled out of UpToDate, obviously it's here, shows you the differences between furosemide and sodium excretion. So sodium excretion is a surrogate marker for how well loop diuretics work and how functional they are. And this just shows kind of an interesting side note. This isn't really something I care that you spend a lot of time delving into, but you can read the caption here, obviously, as well as I can. But sodium excretion and furosemide, for a normal patient, quote unquote, and then a patient with heart failure. So you see that heart failure patients have a more difficult time obtaining adequate diuresis than somebody without. So you do see that there's some resistance naturally to the way that loop diuretics work in a heart failure patient. So if you have heart failure on top of your kidney disease, it can be very challenging to treat, and you'll often see those two things go together. But just to be aware that you do get some resistance. Now, the nice thing about loops is you basically titrate them to effect. So you start with a low dose and then work your way up, and then just see how much weight they're losing or how much urine they're putting out. And that's really all you have to do. So you don't really have to think too hard about this type of stuff, but it just wanted to show you this as an example. Now, we've talked about side effects before during heart failure, but just to reiterate, your biggest issues with loop diuretics are going to be electrolyte depletion and fluid depletion, which is how they work. So on the one hand, it's not necessarily a side effect because, well, you know that's happening, but you just need to monitor for it and make sure that you're not going to overdo it. And so checking your potassiums, your magnesiums, calcium to a lesser extent, and hydrogen ion concentration are really important. There's a slight risk of kidney stones with loop diuretics because they do cause an increase of calcium within the lumen. However, I think it's relatively low because also you think about how much fluid loop diuretics are pushing through the kidneys. There's not going to be a lot of chance for the calcium to build up and accumulate. It is a risk, but generally speaking, it's low, and I wouldn't necessarily worry about it too much unless the patient has had a history of it. The other things I'm not super worried about, there's a couple little things to touch base on here. Ototoxicity is mostly the highest risk with furosemide and people on continuous IV infusions of it. So really high doses for long periods of time. There's also an older loop diuretic that I didn't mention called ethacrynic acid, which is not used very often because of its significant risk of ototoxicity. And the only time we use ethacrynic acid now is because of this little bullet point at the bottom. So all loop diuretics, and actually all diuretics in general, have a sulfa moiety on them, and the only one that doesn't is ethacrynic acid. So if somebody has a sulfonamide or a sulfa-related allergy, particularly the common antibiotic Bactrim, which is sulfamethoxazole with trimethoprim, if they've had a reaction to that in the past that's allergic in nature, you would maybe consider not using a loop diuretic. Now, the cross-reactivity isn't well published, and it's thought to be relatively low, but if they've had like anaphylaxis, that would give me pause to prescribe somebody a loop diuretic. So in those cases, if somebody does have a significantly well-documented sulfa reaction, what you could do is challenge that if they're in the hospital. I wouldn't recommend doing that as an outpatient, The other option you would have is ethacrynic acid as a drug, because that does not have a sulfur moiety. But with that one, of course, you get the ototoxicity risk. All right, and then as far as electrolyte replacement goes, generally when anyone's on a loop diuretic chronic regimen, they're going to be taking potassium daily. So this usually corresponds to 10, 20 milliequivalents of potassium is what they're going to be taking daily, and that can be titrated based on labs and things like that. But it's rare to see somebody on a daily loop diuretic without potassium as well. These just waste potassium substantially, especially when somebody's taking them daily and chronically. So to replace the potassium is just a no-brainer, and it kind of counterbalances one of the biggest risks with loop diuretic use is that hypokalemia. We can fix that by just simply replacing with potassium products. Magnesium, you do need to replace magnesium if you're going to replace potassium too, but it depends on how low the mag's getting. And generally with loop diuretics, mag doesn't waste quite as significantly as potassium, but certainly you might see somebody on a regular magnesium supplement as well to keep that replaced. So those are really common. Inpatient side of things, generally these are nursing run protocols. So we're going to talk about electrolyte replacement in the next series of lectures. So I'm getting a little ahead of myself here, but basically as a provider, all you do, it's kind of like a heparin protocol, but obviously different drugs. But what you do is you'd order potassium or magnesium replacement on this patient. The nurse will coordinate labs, check the labs on a regular basis. And if the potassium comes back low, they plug it into kind of a calculator type tool and it tells them how much to give. They send that order through to pharmacy. As pharmacists, we verify that and make sure it makes sense based on the lab values, and then we approve it. So from a provider perspective, replacing electrolytes is relatively easy. All you kind of have to do is follow along peripherally. But just know that for loop diuretics, I highly recommend, especially if your patient's inpatient, order that replacement protocol so that they're replacing it and checking the labs as they need to. Back to thiazide diuretics. So thiazide diuretics definitely take a back seat for CKD. These are also renally filtered and actively secreted. So the lower the kidney function, the worse performance you're going to get out of these. In fact, under 30 GFR, 30 mil per minute GFR, you're probably not going to see much effect from a thiazide diuretic. And then, the mechanism we talked about during hypertension, it's there for you for your review. But basically, we use these for hypertension. Outside of that, the only time these would be used for CKD would be in early CKD, or possibly to try and get some synergistic effect on top of an existing loop diuretic regimen. These also have a sulfur moiety on them. So just to reiterate, that's something that you'd have to be concerned about as well in those particular patients with that allergy. And this is just for your reference as far as a comparison goes. Thiazide diuretics have a much less one-to-one type relationship as far as going from one to the other than you would do with a loop diuretic. You'd do that much more commonly. With thiazides, mostly, people are just on HCTZ for blood pressure management, and maybe chlorthalidone if they want, something with a little bit more potent duration. But some of them do come IV, so chlorothiazide is available IV. The one you're probably going to see most often for patients with CKD or heart failure, if they're on loop regimens, it's going to be metolazone. And they're going to be taking that as an as-needed adjunct option for them to improve diuresis using that synergistic effect that you get with thiazides on top of loops. It's by far the most potent one. You're probably not going to get a lot of additional diuresis and benefit in a CKD patient with chlorthalidone or HCTZ. So really you're probably looking at metolazone. Indapamide's kind of an oddball. I won't test you on that one, but it is technically a thiazide diuretic as well. Side effects. So you do get some potassium wasting on this one as well, along with magnesium. And then you also can see some calcium effects. I don't think I finished my thought here. With a thiazide diuretic, you can actually use them to treat kidney stones. So the reason is because they retain calcium and minimize the amount that gets excreted into the urine. Therefore, you don't get calcium buildup, which can be useful for that particular disease. So if people are chronically getting kidney stones, they might be prescribed a thiazide for that particular reason, which can also cause an increase in serum calcium, usually not clinically significant, but you might see that as well. Thiazides have something called photosensitivity, which happens with some antibiotics we talked about earlier this year. And hydrochlorothiazide is notorious for this, but people can be really sun sensitive on it, so they'll burn easier in prolonged sun exposure. So that's something to educate patients on. And then there's some rare things here, which I honestly don't really care too much about. They're odd side effects that don't really associate with this particular drug. Replacement protocols, specifically potassium, might come into play here. These do waste enough potassium to make it significant. That's where maybe coupling this with a potassium-sparing diuretic might be beneficial, especially for hypertension. That's why it's done really commonly. Not essential, but it is a common protocol. In CKD patients, they're probably going to be on a loop diuretic already and getting potassium replaced because of that. So you probably don't need the potassium-sparing diuretic on top of this. It probably doesn't hurt, but you don't necessarily need it. And again, the sulfa moiety is on here as well. Potassium-sparing diuretics, we've talked about these and where they really work. They don't have a major role in CKD management, so I'm not going to talk about them any more than we already have. Just a chart comparing them again. And some side effects. Obviously, they're going to increase potassium. One of the things to be careful with in advanced CKD patients, if you're using a potassium-sparing diuretic, CKD patients, one of the main things you'll see in a patient who is right up until their dialysis appointment or misses a dialysis appointment is they get really high levels of potassium, which can cause significant problems, which we'll talk about in a coming up lecture. But the nice thing about these drugs is they kind of mitigate the side effects. However, you get potential risk for even compounded hyperkalemia, which can be cause cardiac arrhythmias and things like that. So it's quite deadly if it's not treated correctly. So we need to be careful with that particular one. There's some other things on here too that I'm not super concerned about because they aren't really relevant for CKD. So over time, diuretics patients can become resistant to the effects of diuretics. And this can just be natural progression of kidney disease. If somebody's CKD is progressing further and further down the ladder as far as their GFR reducing, you get less drug to the site of action. So that's not necessarily your body being resistant to the drug, but your body being unable to get the drug to where it needs to go. Some other things that actually can cause resistance are high urine protein, which can cause a nephrotic-like syndrome. High salt intake, chronic salt intake, sodium consumption can also do that. NSAID use can block afferent arterial vasodilation, which can also cause a compounded issue and acute kidney injury, actually. And then there's something called a breaking phenomenon with loop diuretics, where the distal tubule cells just hypertrophy over time. And that's just because they get essentially worn out. You're constantly overworking the system by using loop diuretics, and that's only sustainable for so long before the body will eventually succumb to resistance to that pathway. So to treat diuretic resistance as an outpatient, you want to look at, is the patient compliant with their diuretics? So this would be an example of somebody you're prescribing loop diuretics for, and for some reason they just aren't really working. So is the patient compliant? Do they consume too much salt? Do they maybe need a referral to a dietitian to go over labels and salt intake with them? Are there drug-drug interactions potentially at play? Specifically, NSAID use would be one be at top of my list to look at. Two would be optimize their dose, increase as needed, or maybe consider changing to a different diuretic, a more potent one. Consider combination of diuretics. So if loop resistance is suspected, you could consider adding thiazide diuresis on. Inpatient is basically the same as above. However, the only difference is you can do IV, which guarantees that you're getting full bioavailability, which is an advantage in and of itself. The other thing you can do inpatient is a continuous IV infusion, where you're getting the loop diuretic constantly to the patient, and that can have some benefits as well. And I think I've got a slide on that coming up here in a second. But let's talk about an example of a patient who might need inpatient treatment of CKD. So this would be using furosemide. Furosemide is going to be the more common one that you see. It's generally the standard starting loop diuretic. So when a patient in this situation is getting 40 milligrams IV of furosemide, they have a GFR between 10 and 50, and 100 milligrams for a GFR less than 10. So that's kind of where you'd start a patient on. If they came in, they're sort of having an acute exacerbation of CKD, not necessarily acute kidney injury, but they're having enough fluid retention or maybe electrolyte retention where they're having problems. So we want to assess their urine output over about 30 to 60 minutes after we gave that first dose. If we had a positive response, administer a single effective dose as often as needed to achieve goal diuresis. So usually that's going to come down to 2 or 3 times a day for IV diuresis. If you don't get initial response from that therapy, you can double your dose until you get that desired effect, or you get a ceiling dose, which ceiling doses in loop diuretics is a little bit debatable. I'm not concerned you know that specifically. Then you want to assess urine output over 30 to 60 minutes after each dose is increased, and then again, just continue the therapy once you get something that responds. If that doesn't work, piometolazone is what you're going to give to your top dose diuretic. You can give chlorothiazide IV as a thiazide synergy if you can't use the GI tract. So if the patient's NPO, they wouldn't be able to take metolazone, so this would be your other option. Then you want to assess urine output over 30-60 minutes again, and then see if you need to increase. If you don't get any response from those combinations, then at that point your 2 options are continuous loop diuretic infusions, and then ultimately if that doesn't work, you're looking at dialysis. So the continuous infusion of the loop diuretic basically is just a scheduled dose of diuresis per hour. And you can see that we're talking about doses earlier of 40 milligrams of furosemide, maybe up to 80 milligrams a day. Sometimes you might see, I think the highest outpatient doses I've seen people on would be like maybe 80 twice a day. But this is a lot. So if you think about 40 milligrams per hour over a 24-hour period, that's a substantial amount of even just the 10 milligrams per hour at the lower end. So you're giving somebody a ton of loop diuretic continuously. The nice thing about this is that you get more of a steady state level, which can prevent big spikes in serum concentration, which can lead to lower levels of ototoxicity. I know I said earlier that ototoxicity is associated with higher loads of furosemide, which can happen in a continuous infusion, but generally you actually avoid those peak levels, so you can maybe get under those toxic levels that way. The increased sodium excretion when compared with the same total daily dose given periodically. So that's, I'll show you a chart on that, but basically you get better overall excretion of sodium, which again is a surrogate marker for how well the loop diuretic is working, compared with if you gave the same total daily dose but split it up into multiple intervals. Disadvantages: time intensive. You have to prep a drip. You have to monitor while you're infusing. A nurse has to set it all up and use an IV pump and all that stuff. It's more expensive. It's more drug. You can also get distal tubular hypertrophy faster with continuous infusions than you would with intermittent dosing. So here's an example of somebody who got diuresis. So you got your peak. So the blue line is a bolus dose. So you give an IV bolus and you get an initial increase of sodium excretion, which is pretty high, and then it tapers down after a little while. And remember, loop diuretics take a little bit of time to work, so you're looking at about a half hour or so to see the start of your diuresis. And that drops off, and then you give another one, and you can see this effect gets pretty high. Now, if you start the infusion off, it's sort of low, but you don't get any drops in coverage. So your area under the curve is substantially higher with the continuous infusion than with bolus dosing. Now, ultimately, you'll see both strategies have diminishing returns over time. You just don't get the same effect. So loop diuretics do have that hypertrophy effect, which is why dosing them intermittently can have some advantages in patients. That's generally what we prefer, but infusions are necessary in some cases. So therapeutic goals, we're usually looking at urine output. So this isn't possible for outpatient, really. We can't just sit there and have somebody, pee into a catheter bag and measure their urine and figure out what it is. And maybe you could do that, but it'd be logistically difficult. In the hospital, it's a lot easier to do that, especially, again, if the patient's catheterized, you can look at how much urine they're making. You want to try and target 100 mils per hour. Outpatient, basically, you want to eliminate signs of edema without causing nocturia. That's usually kind of your sweet spot there. And then dehydration. So we don't want to over-diurese somebody. So that gets more aggressively, as far as aggressive electrolyte depletion and aggressive decreasing fluid status can cause problems not only because of the electrolytes, but also can cause increased in kidney damage because of the dehydration status. Which leads us very nicely into the acute kidney injury topic. The Rifle criteria is just a set of parameters that defines acute kidney injury and what your risk is. So GFR decreases and creatinine increases is generally what we're looking at off of baseline. That's really all there is to it. There's a couple different types of acute kidney injury. They all present basically the same. Pre-renal is going to be something outside of the kidneys causing decreased blood flow to the kidneys usually, whether it's a volume or fluid issue, sepsis with systemic inflammation, or just general decreased perfusion like a CHF exacerbation. This is the most common form you're going to see of acute kidney injury. Post-renally, obstructions post-renal, an example of this might be a inflamed prostate in an older male. Intrinsic could be things like drug-induced. So we're going to talk about a couple examples of that, but this is something happening within the kidney itself. So false alarms, first of all, some things just elevate serum creatinine without any actual kidney injury, and these are pretty mild. There's a lot of drugs that do this, and I've listed them all out here. I'm not concerned you know any of these, but it might just be good to look at them. Like, I don't think aspirin really causes this, but technically it can. What you might see, for example, people on Bactrim or sulfamethoxazole trimethoprim, you'll see a transient increase in their serum creatinine because it inhibits actually the tubular secretion of creatinine. So it's not that the kidneys are failing in any way. It's just our biomarker isn't able to get secreted the way it naturally would. So you can see a bump in creatinine when you have somebody on trimethoprim. It's no sign of kidney disease, but it is something that might be concerning. So that's an example of how some of this stuff works. And then some of it just interferes with the lab assay. It doesn't mean anything, but it just shows up as creatinine on the lab assay. And that can ultimately cause a little bit of alarm because you see an elevated creatinine and you're like, oh, they're on cefoxitin. That's why. Again, not super common, not something to be really concerned about. I don't think you'd probably have to be on a ton of vitamin C to even see that happen, but it is possible. Pre-renal. So pre-renal effects, we really want to treat the underlying cause, otherwise you're not going to get anywhere with it. Hydration, if somebody needs increases in perfusion, dopamine is a great drug because there are dopamine receptors in the kidneys. So not only can you have the vasopressor effects from dopamine, but you also get increased mesenteric blood flow, and that can help be renally protective. There's a drug called phenoldiprem, which we haven't talked about much or if at all, which can lower blood pressure. So if somebody's really hypertensive, it can drop their BP, and it works through the kidneys to do that. Also, early dialysis can help too to get some fluid off the patient if they're fluid overloaded and to get those kidneys processing. Post-renal, again, kind of the enlarged prostate is the common one I think of. Kidney stones. Different type of malignancies can cause this as well. Structural abnormalities. Nothing we can really do about that. Most of those are surgical interventions, or again, nothing. Sorry, I say we. I meant I. Nothing from a pharmacy perspective we can really do about that. Intrinsic renal disease. So you have interstitial nephritis, acute glomerulo. I can never say that. Nephritis, and acute tubular necrosis. Acute tubular necrosis is the most common intrinsic form. And you usually see it with toxins is probably the one I'm most common with. So this is going to be some sort of a drug causing damage to the kidneys. And I think of the big ones being your NSAIDs in combination with an ACE inhibitor in combination with a hypovolemic state. So think about somebody who, think about somebody who's got maybe some underlying hypertension. They take lisinopril on a daily basis. They're maybe out exercising in the hot sun, they get really volume depleted, or maybe they injure themselves or something, then they take ibuprofen on top of that. They haven't drank enough water. That's a recipe for acute kidney injury. So some specific drugs that can cause things, I've got them listed out here. Basically, with any of this stuff you're looking at, you just want to remove the nephrotoxin and correct as many reversible causes as you can. Rehydrate if you need to. Force diuresis with loop diuretics. The important thing about this, never force diuresis if you're fluid under. You have to replenish your fluids before you try and diurese the patient off. Again, kind of similar concept here. Stop your offending agent. Acute interstitial nephritis can happen from some autoimmune diseases too. In those cases, usually high-dose steroids to suppress the over-immune response are indicated, but that's going to be limited to these particular things. You might probably most commonly would see this with patients with lupus. If they have kidney disease, that can be a presentation they'll have. So I've talked about this before in at least one other lecture. I can't remember if I talked about it during ACE inhibitors or NSAIDs, but we'll review it again here. So you have the whole ACE inhibitor NSAID concept, I think, is really important because these are really common medications that lots of people take on a daily basis, and lots of people take them together. And for the vast majority of patients, if you're on an ACE inhibitor or an ARB, you can take an NSAID here or there for pain without any issues. The problem becomes is if you take your NSAIDs chronically in addition to your ACE inhibitors and you drop in volume, that's sort of the three component recipe for acute kidney injury in my mind. So the mechanism, just to review, you have the afferent arterial, and what happens is you get a response to decrease in renal blood flow by increase in vasodilating prostaglandins. Remember, our NSAIDs decrease those good housekeeping prostaglandins, so you don't get that natural vasodilation. So the afferent arterial is constricted with NSAID therapy, meaning that blood's not flowing in as well. The efferent arterial is the exiting one, and E for exit is the way I always remember it. And this has a response to decrease in renal blood flow by preferential constriction of the efferent arterial, and that's all managed by angiotensin II. So if you're decreasing the production of angiotensin II via an ACE inhibitor or blocking its effects via an ARB, you're going to prevent that from happening. So you're going to have a more dilated efferent arterial. So you're constricted coming in, so your flow goes down, and you can't build up pressure because your efferent arterial is more dilated, which is going to give you a picture in here that's going to make it so that you can't build up pressure, and ultimately that can cause damage. So summary, address your underlying cause, hold your nephrotoxic medications until the system's resolved, and then make sure if you're going to restart something, make sure there's good education about what to take and what not to take. Fluids and diuretics are really your mainstay of treatment, and you're going to follow your serum creatinine trend. Remember, this lags kidney function, so when you start to see your serum creatinine come down, that means your kidneys are all quite a bit better than what you might see from a GFR perspective, because it's going to take a while. Once the kidneys come back online after an acute kidney injury, it's going to take them a little bit to clear out the excess serum creatinine, but eventually it'll get back to normal. Most patients survive acute kidney injury with very little long-term complications. Okay, now we're getting some of the more complications of managing a CKD patient and how we might need to treat them. So metabolic acidosis. Patients who have CKD tend to be on the acidotic side. Remember, our buffer system within the kidneys is not going to be functioning optimally, mostly due to decreased production of ammonia, which leads to decreased acid secretion, which causes a buildup of hydrogen ion. So CKD patients are generally going to generate less base per day less base than a normal person, so they can't neutralize all of that acid. So serum bicarb is going to be lower in a CKD patient, and that's again representative of our natural buffer system and how healthy it is. In case you want a diagram for how the ammonia system works to buffer, there you go. As far as the effects of metabolic acidosis, why we care about this, for particular diseases, bone disease, so increased calcium resorption from the bones into the blood will occur as a compensatory mechanism for metabolic acidosis. Releasing calciums from the bones into the serum acts as a natural buffer, and that's fine in the short term, but long term that can cause increases in osteopenic risk and osteoporosis, especially if you have a patient already at risk for those things. It can cause hyperkalemia, fatigue and exercise intolerance, and protein catabolism, because another compensatory mechanism is your body will break down muscle or protein to produce ammonia This increases BUN, and it also, over time, while it works temporarily as a buffer system, it will increase the risk of renal damage, having more protein byproducts and peptides getting pushed through the kidneys. So your initial strategy is just to replace the bicarb. And so when the CO2 content drops below, remember CO2 and bicarb are the same thing. Sodium bicarbonate, CO2 bicarb, it's all the same thing we're talking about here. And so you really want to target your pH goals. Ultimately, if somebody's end stage, they're going to have to use hemodialysis and replace it just during the dialysis session. But for other patients, you can use specific alkalinizing agents. Polycitrate C is potassium citrate, which is basically citric acid. This is helpful if the patient has low potassium. If their potassium is elevated, you would want to use something else like sodium citrate or citric acid or sodium bicarbonate. You can just replace bicarb with bicarb, and that you can do orally or IV. It's pretty easy to replace that way. I'm not going to test you on how to replace this, but as an example of how you might want to replace, this is the basic strategy here. The big thing to remember is if somebody's potassium is elevated, you don't want to use a potassium product. Whereas sodium can fluctuate a lot more. You can get really high sodium levels without really causing any clinical significance. And sodium is a lot easier for the body to maintain versus potassium. Outside of standard normal lab values, you end up with significant cardiac complications. So that's a much more important one to watch. Here's just an example of calculating bicarb. It looks confusing, and it kind of is. It's a little bit more simple than this. In most cases, we just target a pH, give your bicarb, and kind of titrate to effect. Whether it's oral or IV, it doesn't really matter. You just want to monitor to make sure you aren't overdoing it, and that's the big thing. And then monitor your electrolytes, too, to make sure nothing's getting out of whack that way. There are some aluminum-containing and aluminum-containing antacids that can cause issues. So that's something, generally speaking, giving with a citrate product, you can actually increase the absorption of aluminum, and it can be toxic if you get too much in. So if somebody takes Maalox or Gaviscon for heartburn regularly, they could potentially be at risk. So it's something to think about, especially if somebody has CKD. They probably aren't going to eliminate the aluminum as fast as a healthy person. And that's something that could potentially cause complications. For anemia and CKD, it's really treated the same as any other anemia. So these patients have decreased numbers of circulating erythrocytes. Remember, our erythropoietin production is suppressed when our kidneys are damaged. People have low hemoglobin. And then they might also have things like they have ongoing blood loss going on, or iron, folate, or B12 deficiency, or bone marrow suppression if they're undergoing some sort of process that would cause that as well. That would be other things that could put people at higher risk for anemia during CKD. Most patients who have end-stage kidney disease will need erythropoietin supplementation. So we have a couple different drugs, and we've talked about these very briefly during the anemia and the Hem-Onc lecture series. But what erythropoietin, there is a product that's basically synthetic erythropoietin, Epogen or Procrit, induces erythropoiesis via stimulating your progenitor cells in the bone marrow. And so patients usually get this during their dialysis session. So if they go into dialysis 3 times a week, they get a shot of Epogen, usually with that, or sometimes they might do it weekly, depending on how they're being dosed and what product they're using. There are a couple different things to think about when it comes to epoetin supplementation in kidney disease patients. So the half-life is about 8 hours IV, but that short action is enough to provide long-lasting effects and stimulation. So we really don't care that it's short-acting. If you give it sub-Q, it lasts a little bit longer, but the bioavailability decreases substantially. So that's another reason why it might be nice to do IV if you have the availability. But at the same time, some patients find that this lasts longer, so they get more of a delayed absorption, which also causes a more substantial duration of therapy. And so some people prefer that because it bridges them to their next dialysis session, or they can use it specifically for patients who are more treated on the outpatient side. If you're looking at urgent need to get the hemoglobin up, this isn't going to happen very quickly. That's where you're going to use IV instead. And there's darbepoetin, which has a longer half-life and is longer lasting than erythropoietin, but same concept. So your benefits, alleviates anemia. You basically get 100% patient response. Remember, you're just giving the body what the kidneys can't make directly. So there's really nothing more direct than that. There's not a lot of side effects associated with it. And before they had products like this, they basically had to give people blood products who were an end-stage CKD. Or they just ran really low on their hemoglobin, which is not ideal, of course. So your target hemoglobin when you're treating a patient for this is usually 11 to 12. They did look at higher amounts, so a healthy person probably would be above that, but they thought there's some studies out there specifically that looked at higher hemoglobin levels and showed increased mortality in CKD patients versus kind of targeting a moderate to lower goal hemoglobin. The nice thing about a lower goal is a little bit easier to hit. You don't have to use as much drug to get there. There's a lot of red blood cell parameters, CBC differential you're going to want to monitor, signs and symptoms for bleeding and clotting, because it can affect that as well. But overall, there's not a lot of issues with giving EPO. You just have to make sure you're not going to overdo it. That's really the big thing here. So you're normally going to wait till your CKD patient's hemoglobin starts to drop below 10 chronically. For pre-dialysis CKD, you can usually just get by with sub-Q 3 times a week. If somebody is getting hemodialysis, they're going to get the product with right before each hemodialysis one, which is also going to be 3 times a week. So it's really no different per se. It's just when they're getting it. Peritoneal dialysis again, I'm not going to talk a ton about the different dialysis types. I hope you get that somewhere else because it doesn't really necessarily affect pharmacy per se. But for peritoneal dialysis, if you aren't familiar with that, so hemodialysis is, you basically filter the blood directly. Peritoneal dialysis, you use the GI membrane as a filter. And so you basically would, you infuse dialysis, or it's almost like not irrigation, I don't know exactly the word, but you put dialysate into the peritoneal cavity, and then that actually works as a concentration gradient, and then you kind of exchange it throughout the process. From what I understand, peritoneal dialysis is really common in Europe and maybe other countries, whereas in the US, we primarily just do hemodialysis. For darbepoetin, it's a little bit different dosing, and it's usually once a week for dialysis patients. If you aren't on dialysis, the big advantage here for darbepoetin is it's every month for an injection. So for patients who are pre-dialysis CKD needing EPO, darbepoetin has some significant advantages there. It's more expensive, but it probably has some cost savings when you think about how little you have to actually give to get the correct amount. And actually, even with dialysis, you can do every 2-week darbepoetin. Monitor hemoglobin every 1 to 2 weeks until you're stable, and then once a month. Some of the things to think about: you don't want to increase your hemoglobin too significantly. If you go up by more than 1 gram per deciliter in 2 weeks, you want to decrease your dose. If you go down, or if your increase is less than 1 gram per deciliter in 4 weeks, you increase the dose by 20%. I do want you to know this, not necessarily because I'm concerned you know how to dose EPO, but I want you to know that that's really the major parameter for EPO, is we want to avoid these really drastic changes in hemoglobin. So if you remember the 25% rule, you'll be just fine for the exam. So know that if you get a drastic increase in a hemoglobin post starting EPO, you're going to want to drop your dose by 25%. And if you aren't getting the response you want in a month, you want to increase that dose by 25%. For full effects with EPO or darbepoetin, you have to wait about 8 to 16 weeks. So it takes a little bit of time to see the complete effects start to kick in. If you overdo it, the risk is that you can, they've shown that you have increases in thromboembolic or cardiovascular events with that. And remember, just because depot is more convenient, not all patients will have it covered, and it's quite expensive as well. Iron replacement. So we can use iron for patients who have iron-associated anemia. So we usually have iron given with hemodialysis patients, IV. Iron is a difficult thing to take orally. It generally causes GI discomfort. People don't tolerate it very well. It doesn't absorb very well out of the GI tract either. So if you can give iron IV, that's generally the preferred way to do it. The average hemodialysis patient is going to get about 200 milligrams of iron a month, usually every 2 weeks or every week. It's usually not with every hemodialysis session. The products, there's iron dextran, gluconate, and sucrose. We're usually using sucrose for the vast majority of patients. And it's the only product approved for all types of dialysis, including, and then non-dialysis CKD as well. So that's by far and away the one we use most. All right, bone mineral disease. This gets a little confusing just because this is the first time we've really talked about this. So I recommend just maybe spending some time with some of these charts and descriptions and trying to piece it out together yourself. But we'll come back to this as well during osteoporosis because it affects that as well. And all these systems are in play for that. But people who have CKD are at high risk for developing osteopenia or osteoporosis. The reason is because our kidney is does a couple things. First of all, it can convert a byproduct or a product, I should say, from the liver into active vitamin D. And then vitamin D is used as a cofactor in the intestines to absorb calcium. So if you don't have adequate vitamin D levels, it's very difficult to absorb calcium. If you can't absorb calcium, you can't keep your bones healthy. Therefore, you're going to get issues with increases in fractures and things of that nature. So for these patients, there's a couple different things to talk about here. There's parathyroid hormone, which is directly responsible for increasing serum calcium and promoting phosphorus excretion and conversion of active vitamin D. Vitamin D itself increases your serum calcium and phosphorus concentrations, and it has a negative feedback on parathyroid excretion. So what does this mean? It means that because the vitamin D production is low, patients are going to have high parathyroid hormone, and it's going to promote high bone turnover. Alternatively, overcorrecting this can cause adynamic bone disease, which the bones aren't turning over correctly themselves. So either way, you can end up with problems in CKD patients. The high serum calcium levels may cause intra and extra vascular calcification as well, which can cause blockages in certain areas. Overall risk, your increased risk for fracture, morbidity, mortality, and possibly ischemia and amputation, specifically with extravascular calcification. So for CKD patients, we have to monitor and manage calcium levels, phosphorus, parathyroid hormone, and vitamin D all appropriately. Okay, starting with phosphorus, which is poorly removed by dialysis. And the problem with that is that phosphorus is present in basically everything we eat in some capacity. So people will generally take in anywhere from 1,000 to 1,800 milligrams of phosphorus a day, and only about, well, it depends, I guess. If you're on the low end, you might be okay by hemodialysis. But the point is you're going to get a phosphorus excess at some point, depending on your diet. So end-stage renal disease will get there eventually if you don't do anything. If that happens, you get hypocalcemic, you get more parathyroid hormone excretion, and you ultimately inhibit vitamin D activity. So this whole feedback loop system basically shuts down, which can have negative impact on your bone health. Management and also high phosphorus levels can have problems too, which we won't talk about right this second. But anyway, the point here is that we need to manage phosphorus. So first of all, phosphorus restricted diets are encouraged, but that can be difficult. And I would certainly recommend your CKD patients get referred to dietary to go over strategies for reducing phosphorus. But dairy, chocolate, beer, cola, nuts, seeds, whole grains, all that stuff has high phosphorus in it. And avoiding that completely is challenging. So what we can do is bind phosphate. So this is I call it the second step after you try your dietary measures, but most patients are going to have to do something like this. So you take it with meals, your phosphate binders, and this basically just prevents phosphorus from getting into into systemic circulation because it gets bound up in the GI tract and gets excreted instead of absorbed. So there's a couple different ones out there. There's calcium and aluminum based. The most common one is calcium, and it's calcium acetate, which is Phoslo. So technically any calcium product should help. And these are relatively cheap, but Phoslo is going to be the one that's used most commonly. Calcium, it is constipating, so it's probably the biggest side effect of giving calcium. And if somebody's serum calcium is elevated, that might be something we would avoid. And if their PTH is really low to begin with too, you might avoid that as well, because the increase in calcium won't help that. The other options we have are hydroxide and carbonate salts that are aluminum. Don't worry about aluminum products. They aren't used ever unless the calcium is super high, which is really honestly unusual to see. And the other ones, sevelamer and lanthanum carbonate, are different they do the same thing, but they don't have any calcium or aluminum or magnesium to consider. They're a little bit more expensive, but if patient have vascular issues or complications or can't use the calcium product, these would certainly be your first line. The other nice thing about these is you can actually combine them with a calcium. So if somebody's on calcium acetate and they aren't getting the response they need, adding these on is something that's done really commonly. So I'm just going to bold calcium acetate and these ones, because those are really the ones we use. Don't worry about the aluminum ones. And while calcium carbonate products like Tums and Rolaids could technically be used, they aren't as effective, and they aren't packaged in a way that's as convenient to take, whereas calcium acetate comes in nice capsules that are easy to consume, whereas you'd have to like chew Tums up to get what you need, and that can be annoying for patients. Okay, so flipping gears a little bit, one thing I'll just say for phosphate before, phosphate binders are really common for CKD patients. You're going to see them basically used, especially for dialysis patients. They're almost a required therapy for everyone, so it's really common. If you see calcium acetate on somebody's med list, that's a giveaway that they're a CKD patient or kidney disease, or a dialysis patient, I should say. Okay, for calcium, you can use a total corrected calcium equation to give you the actual serum calcium, or you can get an ionized level to get a better picture. But the point is that you want to look at calcium. The nice thing is calcium variations that are ones we care about are pretty rare. They're possible, but hyper is going to be more common. It's rare to see somebody get hypocalcemic with CKD. If you are hypercalcemic, so if your calcium's high, you want to reduce your PO intake. You can use non-calcium phosphate binders, so sevelamer or lanthanum would be options there probably to go to, and reduce or temporarily stop any vitamin D supplementation. Again, not commonly seen, but those are be your options. All of those are relatively easy things to do. You don't have to react aggressively to high calcium. You just stop or implement these things, and then it would just slowly get lower on its own, and then you can resume therapy wherever you see fit. When somebody's hypocalcemic, you want to treat and correct calcium if it's less than 8.4 and if the parathyroid hormone is elevated. And this you would switch to a calcium-based phosphate binder if you weren't using it. Again, it's going to be really rare to see people get hypocalcemic because most people are going to be on calcium acetate. So that's really the easiest thing. Most people also will be on some sort of vitamin D supplementation, which will give them the ability to absorb calcium well. So hypocalcemia in CKD patients that are managed correctly is going to be extremely rare to see. All right, vitamin D. So the effects in CKD, it promotes calcium and phosphorus absorption, increases calcium resorption from the kidneys, unless you're end stage, and then it's not going to do anything there. And indirectly and directly decreases PTH. It also decreases bone resorption. So it's got a lot of beneficial activities it does in the body. There's a couple forms to think about. So ergocalciferol is D2, which is the inactive form of vitamin D. It's converted to calcitriol renally and hepatically, and used if you want to use this if your ergocalciferol or vitamin D2 serum levels are less than a certain benchmark. I don't care you know this, but the thing to remember about this is if you give ergocalciferol, your ability to convert it into the active form is really limited in CKD patients because it's primarily done in the kidneys. So something to consider. Usually we don't use inactive vitamin D in CKD patients for that reason. Now, if you gave ergocalciferol as a supplement to a person with healthy kidneys, they're going to convert it to the active form just fine. Fortunately, calcitriol comes as an active form. It is a prescription product, so you can't go over the counter and buy calcitriol. There's also a IV version of this called paracalcitriol, or paracalcitol, or brand name is Zemplar. So a lot of patients, when they get their dialysis runs, will get an injection of Zemplar at the same time. There's another oral product called doxorcalciferol as well. These products don't require any renal conversion, and they give you the access to the they give your body access to active vitamin D immediately. So they're preferred over any other type of vitamin D supplementation. So if you see calcitriol, that's a common one for a CKD patient to be on. Cautions, you might see increases in calcium or hyperphos, but assuming we have phosphate binders going, we should be fine. But the high calcium levels, again, generally not clinically significant. Usually they don't get high enough for us to warrant any type of change in therapy. And then we have parathyroid hormone management. So treating hyperparathyroid hormone is going to be looking at managing the phosphate binding aspect and supplementing vitamin D. Generally, if those two things are done correctly, your parathyroid hormone should be normal. There is a medication called cinacalcet or Sensipar, which increases sensitivity of the calcium sensing receptor on the parathyroid gland. This ultimately lowers parathyroid hormone, serum calcium, and serum phosphate levels. It's got pretty potent effects and it works pretty well, but basically you would only give this if somebody was optimized and just wasn't responding to optimal vitamin D and phosphate therapy. Toxicity can include low calcium and low phosphorus. Otherwise, it's fairly well tolerated medication. If your PTH is low, which would generally be a little unusual, you'd want to hold or reduce vitamin D or calcium-contained phosphate binders until it pops back up, or consider switching to one of the non-calcium containing binders. So summary here, you've got two types of bone disease. You've got high turnover, which is going to be high parathyroid hormone, or low turnover, which is normal to low parathyroid hormone. You want to avoid overtreating high PTH with calcium-based phosphate binders. Vitamin D and cinacalcet can result in suppressed PTH and lead to adynamic bone disease. Calcium, phosphorus, and PTH should all be measured in all patients with reduced GFR. So as soon as they qualify for any type of CKD, you're going to want to start monitoring these things and treat as needed. So basically, the treatment's fairly straightforward despite a lot of complicated stuff we just talked about. Control your serum first with phosphorus, and that's via diet and binders. After that, you want to check your vitamin D levels and treat if parathyroid hormone is high and vitamin D is low. And then if for patients with refractory high PTH, you want to consider cinacalcet. That's really all you need to do. So control your binding, treat your vitamin D, and if that's all done well and your labs look good on that aspect, but your PTH is still high, cinacalcet's what you're going to add on. And that's the last slide for this particular lecture. We'll come back to this concept when we talk about osteoporosis and review it a little bit more. But from a renal perspective, I really want you to focus on this stepwise process. So again, just to review, you're going to control that serum phosphorus first using calcium acetate and then maybe a non-calcium binder too if you need something extra. Vitamin D levels, and then treating if your parathyroid hormone is high and vitamin D is low, supplementing with calcitriol or IV paracalcitol if you need that. Consider cinacalcet for those refractory patients with high, remember that refractory means that their PTH is still elevated despite having adequate vitamin D and phosphate control in their regimen. And then you just monitor and make adjustments as you need to.